Yes, I still do have my Ranger tickets and my jet tickets. So if anyone wants to go, just send me a message and I'll try to get you there. Nice tickets too on the bridge. I don't know if you guys sit up there, but very nice. Okay, so we're going to go. First of all, I'd like to thank everyone for all the presentations. This has been an excellent conference this year, and all the presenters have done a really amazing job, so it's going to be very difficult to follow. But I'm going to, hopefully, we'll have some fun with statistics, and we'll go over how to interpret some of these things. We're going to use Bob Freiberg's paper on topical oxygen in order to take a look at, some of the tests that he used, and I think we see these pretty often, so let's get right into it. So some important definitions. This is kind of outer space look down, population, sample, random sample, parameter, statistics, inference. It's very complicated, but if you think about it in a stepwise way, a population is everyone that is in New York State, let's say. And if we want to study that population, but we can't get every single person in New York State. So what we're going to do is we're going to take a sample of that, and this is inherent in all research. So what we're going to see is that a sample is actually a collection of that population of interest. So in this case, it would be diabetics from New York State, for example. Okay, and a parameter is just how we're going to talk about the population as a whole, and a statistic is really when we're talking about that sample that we're studying. So just to kind of give you a little intro into that. Okay, other important things that we want to always keep in mind is what's the internal validity of our study, meaning how well is the experiment done, how good is the tool you're using. If you're using a Semmes-Weinstein, monofilament, if that Semmes-Weinstein is from 10 years ago and you've had it in your pocket all this time, everyone's going to have neuropathy as the monofilament is basically degraded at this point. You might have a completely new study, but your validity is very poor. And your external validity is something, how can we generalize? How is my study related to your patient population? So if I'm only looking at females and your population is all males, it's likely that my study doesn't have a lot of external validity for what you might be interested in. So it's very important to kind of keep these things in mind when we're reading studies to see, this might be an interesting study, but does it apply to the patient that's in my chair or the people that I see generally? And how do we maintain this? We do it through random assignment to kind of limit these kind of, or increase validity, lab-controlled testing, and you want to select the right instrument, blinding, etc. Okay, so this is one of my favorite studies to use from Bob Freiberg. This is a great study. It's a randomized, double-blinded, placebo-controlled trial looking at topical oxygen, for the treatment of chronic diabetic foot ulcers. I'm not going to really get into this particular study, but I'm going to just pick statistical tests that he used, and I'm going to go through each one of them. This way we can all kind of understand them as we go through. Okay, now this is the most important slide of this entire lecture. And this is, a student's nightmare, I think. Hypothesis testing is the basis of all research, and I'm going to try to explain this to everyone in a very simple way. The null hypothesis is when you're looking at two samples, okay, your control sample and your study sample. The null hypothesis is always that these two samples are going to be equal. And your alternative hypothesis is that one sample is going to be different than another sample. That doesn't mean better or worse, it just means different. And the way that we do that is we're going to use something called a p-value, and we're going to kind of talk about that to see how to interpret this, right? So how do you interpret your p-value? And there's a lot of different ways to interpret it, but essentially it's the likelihood that the result that you're getting if the null hypothesis is true. So it's a probability. So let's just take, for example, a very simple idea. If sample 1 has a mean age, meaning an average age of 70, let's say, and sample 2 has a mean or an average age of 71. Now, what that 0.05 probability is that there's a 5% chance that if you were to take that sample all over again, that you would get a number that was different than that 70. So that's really all it is that 5% is the variability, if you will, of that test being reproducible. So in some ways, if it's less than 5%, we can accept that the null hypothesis is true, that those two values are different. Hopefully that clears that up. Maybe not. So going further with this, type 1 versus type 2 error, this is very important, again, for that hypothesis testing. So type 1 is the likelihood of rejecting the null hypothesis when it's true. So the null hypothesis, again, is that the two samples are equal. So we don't want to reject the null hypothesis if it's true. We want to find a difference between our control and our placebo arm. So a type 1 error is something that we really don't want to see, and technically it's a false positive type of error. And a type 2 is failing to reject that null hypothesis when it's negative, failing to reject that null hypothesis when it needs to be rejected, when it's false. So by doing this, you can lower the alpha. This kind of can help you to have stricter criteria in order to make sure that you're going to be reducing type 1 error. And then if you do it the opposite way, if you make the alpha larger, you'll have a greater chance of the opposite error. So let's look at individual tests. So for the rest of this talk, we're going to kind of go over what a student t-test is, how to interpret it, what a chi-square test is, how to interpret it, sensitivity, specificity, positive predictive value, negative predictive value. These are things we hear a lot about, and they all mean different things, even though they may be very similar. I'm also going to touch on confidence interval without making a big deal, so don't get intimidated. It'll be very quick, and I'll teach everyone basically a 10-second way of looking at a confidence interval and being able to interpret it. Some studies just report a confidence interval with no p-value, so we should be able to interpret that as a group when we're done. And then I'm going to speak a little bit about odds ratio, one of my favorite tests. I'll talk a little bit about how that relates to relative risk. And then we'll look at linear regression and logistic regression, which is another one of my favorites. I did my thesis on logistic regression, so I make everything a logistic regression. So we know him. He actually invented the t-test. Okay, so student t-test, this is really important. You see this nice, and let's see if my marker works here. As you can see, this is a famous distribution, and it's called the normal distribution. Now, what this is showing us is continuous data over the course here. Now, I used an example before where we have the age here. So we see our age in the sham group, which would, in our case, would be the control, versus the topical oxygen group, right? That's gonna be our study group. And then we see the age here. In the sham group, we have 61.9, and in our active or our study group, 64.5. So we can see here that the p-value is 0.21. So we remember that less than 0.05 is showing us a difference between those two groups. So 61.9 and 64.6 in this case there's no difference between those two groups, meaning the ages between the sham and the topical are comparable. So we can't say, oh, this is an old man and we have a little baby here in two groups, so they're not equal. By determining that these two groups have equal ages, it lets us know that we can kind of go forward with more advanced statistics. Now, looking at this distribution, the important thing to take away from this is that the student t-test can only really be used if you have continuous data. And by continuous data, I mean countable, like from 0 to 100, age. Let's say you're looking at cholesterol, something continuous, goals by the Rangers, things like this, score. You can't be looking at male versus female. In that case, it would be binary or dichotomous data. And we're going to have to use a different test for that and a different distribution. So Mann-Whitney, this is, I talk about this because what do you do if you have continuous data, but your population is, your distribution rather, is not normally distributed? So we can't freak out. We have to just use a different statistical test. So what we do is a non-parametric test, which is a Mann-Whitney test. And all that this is when you have a not normally distributed data, you can use a Mann-Whitney rather than your continuous t. And all that is that the t-test uses the average of the two groups, and the Mann-Whitney test uses the median. So if you guys remember that from junior high, so median versus mean. So the Mann-Whitney test is going to be less affected by the distribution. Okay, and here's the chi-square. Again, this is a very busy slide, but I have a picture of the distribution here, mostly because I think it's really cool to compare this versus the normal distribution. As you can see, the chi-square is kind of making your head spin here with all the colors and the different distribution, but hopefully we can try to figure this out together. So again, in this topical oxygen paper, what we can see here is that we have ulcers healed at 12 weeks versus the sham versus the study group. And what we see is there's 15 people that received the topical that healed, and there's 5 people in the sham group that healed. But like we talked about before, we can't use our student t-test because this is not continuous data, meaning healed or not healed. So this is dichotomous data. So we're going to have to use a different test. So the test you're going to use for this is called a chi-square. Now, the chi-square distribution is not that normal bell curve that we just saw. Instead, we're going to have to use this distribution that we can see here. So there's one more complex thing with chi-square, and that's something called degrees of freedom, and that kind of gets us onto the track. So we have, like, imagine each color here is like your railroad track. So degrees of freedom means number of groups that you have minus one. So in this case, we have two groups, right? We have our sham group and we have our topical oxygen group. So we're going to do 2 minus 1, and that's going to bring us to our yellow line. So this chi-square statistic, without getting too much into it, 7.27. So if you see on the x-axis, if you come down where that yellow line is, you're going to come down to where that 7.27 statistic is, and then you're going to get your p-value right here. So you see how it's very low? This is 0.1 on your y-axis, and we can see that the chi-square p-value is 0.007, which is less than much less than 100%. I mean less than 1%. Obviously showing major difference here between your sham and your topical. According to this test, I'd much rather use the topical, right? So sensitivity and specificity, again, this is another very interesting test that we can use, and it's used very often. The most important thing to keep in mind is that for sensitivity, prevalence is not a factor. So there's been some talks earlier today where if you're taking a probe-to-bone test, let's say, in patients that are admitted through the ED in your hospital, most of these patients are going to have osteomyelitis. So if you test anything, they're going to have osteomyelitis. So if you're doing a probe-to-bone in the hospital-based setting, everybody that you test, they have osteomyelitis. It doesn't matter really what test you use, you're going to find what you're looking for. So it's very important to know what your prevalence is, what the disease prevalence is, and then use the test appropriately. So if you're in a situation like that, it would be better to use your positive and negative predictive value of these tests because they're not prevalence-based. So you want to kind of keep that in mind when you're looking at these tests. So if it's in a very high probability area where everyone has the disease in this particular population, like we talked about, or sample, you have to be careful with the tests you use. Okay, so now relative risk versus odds ratio. So these are very, very similar tests, and the only real difference is when you use them and then how they can be applied and how you can cheat. And I'll show you kind of a little statistical way to cheat and something you guys should be aware of when you're reviewing these tests as well. So relative risk is the probability of that an exposed person gets the disease over the probability of an unexposed gets the disease. And the odds ratio is the odds that a case was exposed versus odds that a control was exposed. Seems very similar, and we're going to go over when to use what, and then when it's appropriate and how odds ratio can be a little bit exaggerative. Okay, so relative risk is the most important thing to kind of take away from a relative risk statistic and when you should use it, is that this should really be used in randomized controlled trials or cohort studies. So this is where the patients are starting with no disease and they're ending with that disease. So what you want to start with, for example, would be you're starting with healthy patients, no one with lung cancer, you're tracking the exposure to smoking, and then you're going to see what is the incidence of that lung cancer development in those patients. That's your cohort study. Okay, and for that type of study, you're going to use relative risk. Now, I'm going to kind of mention how you would interpret relative risk, because this is going to become important when we're looking at confidence interval. So relative risk of 1 means there's no difference between the two groups. A relative risk of greater than 1 is going to mean that you're going to be more likely to develop that than not. These smokers have a relative risk of developing lung cancer higher than the non-smokers, let's say. And then relative risk of less than 1 would mean that your intervention is protective against smoking. So let's say, or cancer, let's say it's jogging. You might expect a relative risk of less than 1, as in it's protective against your outcome. Okay, and your odds ratio, this kind of test is very similar to relative risk, except we're going to do this in case control studies. So what this means is, and I'm sure in your institutions you've done this, you start with the outcome and you go backwards. So I'm going to look at everybody that had lung cancer and then see, oh, do I have smoking in those people or not? It's a much faster way to do a study, but using odds ratio is going to do this for us. You cannot use relative risk when you're looking at a case control study. Now, for a cohort study, you can use an odds ratio, but it's kind of looked down upon statistically because odds ratio is similar to relative risk, but only when the outcome is very, very rare. So if you're starting if you're starting at a place where you're going to have that disease process and you're going backwards, your outcome is already built in. It's not a rare outcome. It's something that you're going to find by looking through your medical records. It's your specific outcome. You're going by based on that CPT code, if you will. So what odds ratio will do is it will actually exaggerate that interpretation. So if you have a relative risk of 1, your odds ratio might be a odds ratio of 1.5, let's say, where it'll be exaggerating that finding, and we'll kind of see an example of that in a second. So you can see here, we're looking here at history of smoking and low birth weight, and as you can see, it's the same exact calculation, and like I said, they're very similar statistics. However, you can see the relative risk here is 1.6 versus the odds ratio of 2.02. So the odds ratio has actually been exaggerated. So I like to watch for this kind of thing in pharmaceutical studies where they might choose to use odds ratio because it's going to show a greater benefit, if you will. It's going to show you a more exaggerated example. Now, it's not completely incorrect. However, it is a way to exaggerate your stats. So if you're trying to sell a product, you might want to use odds ratio to exaggerate your finding. Okay, and now confidence interval. This is a very fun one for me because lots of times people and students, especially if the p-value is not there in a study, they don't really know how to interpret it, but the confidence interval is given. So what I want to kind of stress here is we talked about odds ratio, we talked about relative risk and how to interpret it, and remember that number 1 was the most important. And remember our null hypothesis, which is that the two groups are no different, right? So no difference in relative risk and in odds ratio is a value of 1. That means the control is the same as the study arm. So when we're looking at confidence intervals, what we're trying to compare here now is that odds ratio, right? So if your confidence interval contains your null hypothesis, which again would be 1, right, if we were to kind of spell that out, then you can look just at the confidence interval and know, for example, if you have a significant value or not. So, for example, using the Freiberg study here, we can see the odds ratio is 6, right? So when we interpret that, we can say that the topical oxygen group is 6 times more likely to heal than the sham group, and our confidence interval here is 1.44 to 24.93. So what that's telling me, when I'm looking just at the confidence interval, is that I don't see the null hypothesis 1.00 within my confidence interval. So by not seeing that, I can automatically know that this is a significant finding. So hopefully that kind of, that's like your outer space look. I see a confidence interval. I don't see 1.00 within my boundaries. So a confidence interval of 0.98 to 2.5, 1.0 is within that range. So you would be able to say then that the two groups are similar. So there's no difference between those two groups. Now, logistic regression, this is a very fun thing. So this is only for binary data, and that's kind of the most important takeaway from logistic regression. You can't make continuous data into a logistic regression. And the nice part about using logistic regression is that you're able to get to use your odds ratios, which makes your data very interpretable. So kind of the most important thing about any study that's done is being able to explain it to your colleagues. And an odds ratio is a very easy statistic to say, if we use topical oxygen, like in this case, we're going to get an odds ratio of 5, which means that our topical oxygen is going to be 5 times more, our topical oxygen patient, excuse me, is going to be 5 times more likely to heal than our sham patient. So many times, the statistic that you use, if it's easily interpreted, then people can reproduce it, and they're more willing to explain that to a patient. If we use this product, you're 5 times more likely to heal. So people love the odds ratio, and that's one of the biggest reasons why. So lots of times what you can do is to try to make something logistic regression. So for example, if you're looking at, let's say, blood glucose, instead of using serum glucose, you might want to use diabetes, yes or no. Then that can fit into your regression model because now it's a binary statistic versus a continuous statistic. Same thing with cholesterol. If it's high enough, you can call it HLD. If it's not, then it's no HLD. Now you've made that continuous variable into a binary variable, and you can kind of squeeze it into your regression model and you'll be able to use your odds ratio as a way for interpretation. And linear regression, similarly, this is when you have continuous data. So this is a linear regression from a study that was done on wound pH and its effect on healing, right? So wound pH is a continuous variable. The size of the wound is a continuous variable. And the nice thing about linear regression is that you can say, and the fancy way to say this is that, you know, your dependent variable is y, and your independent variable is x, and that essentially y is dependent on x. But a nicer way to say that is you can say that for every change in x, you can expect a change in y. So in this example, for every change of pH that you're getting, you can expect the wound to close by x amount. So for every change in y pH, you can expect a change in x wound size. So that's another nice way to explain this to a patient or to colleagues by saying, you know, if we can get this pH down 1 marker, then we might be able to close this wound by 116 millimeters. So that's kind of the benefit of interpreting these types of tests, is that you can know what to expect from your findings.